Our speaker today is Professor Anthony O'Brien. Dr. O'Brien teaches economics at Lehigh. He has received the Lehigh University Award for Distinguished Teaching. He is a class of 1961 professor and was formerly the director of the Diamond Center for Economic Education. He was also named a Dana Foundation Faculty Fellow. Dr. O'Brien's research interests include the economic history of African Americans, the international economy during the interwar years, and the historical development of nominal wage rigidity. His research has been published in the American Economic Review, the Quarterly Journal of Economics, the Journal of Money, Credit, and Banking, the Journal of Economic History, and that's just to name a few. In addition to teaching and writing, Dr. O'Brien also serves on the editorial board of the Journal of Socioeconomics. Today, Professor O'Brien will apply basic economic concepts to help us understand why healthcare costs have been increasing, what the effects of the recent healthcare reform law are likely to be, and what alternatives there may be. Please join me in welcoming Dr. O'Brien.
Great, thank you very much. So these are the non-football fans. Joe Sterrett is opposite me. When I was told that, I said, I think maybe we could hold this in my office, but I'm glad that we have more folks who've come by. This also, I think maybe some of you know, was originally supposed to be Frank Gunter, who was supposed to give this talk, but Frank, who some of you may know, had a family emergency and had to leave, so I've been pressed as pinch-hit for him. Can you not hear me?
Mic for you to wear.
I'll be right back here. It seemed kind of loud. Is that okay? I'll do my best to stay right here. Usually when I'm in class, I'm kind of walking around, but I'll hover by the microphone. So actually, I'm happy to be here. It's hard for me to believe this is actually the end of my 25th year at Lehigh. It seems like only yesterday that I was here. I don't know whether, probably not many of you had me in class. Actually, I was thinking the other day that a number of the faculty that I knew when I first came in have since retired. I was thinking particularly of Jack Paul. Did anybody have Jack Paul accounting? Oh, okay. So Jack Paul, maybe you know, retired a couple of years ago. What made me think of him was my first day on campus back in the fall of 1987 up at Drown Hall, right before they built the Rout Center. The business college was housed in Drown Hall, now the home of the English department. And I was walking down the hallway, and Jack Paul stopped me. And he said, "So you're the new economist?" And I said, yeah, I'm the new economist. And he said, "Let me tell you about economics. This is a story that has stayed with me ever since." He said, "This is economics." He said, "A man goes up in a hot air balloon, and big windstorm unexpectedly comes up. Right? So he's blown miles and miles in one direction. He's blown miles and miles in another direction. You know, the basket he's in is twirling around. He thinks his number is up. And then the storm abates, and he's okay. But he's hopelessly lost. He has no idea where he is. So he sees a man walking down the road. He leans over the basket and says, "Hello down there." He says, "Hello up there. Can you tell me where I am? You're up in the air in a balloon. Are you by any chance an economist?" "Yes, how did you know?" "Because your answer, while technically correct, is completely useless." So this is my inauguration to Lehigh. If you're a baseball fan, if you're a Phillies fan, you may know that Cole Hamels, right, one of the Phillies pitchers, got in trouble recently when Phillies were playing the Washington Nationals, and he drilled Bryce Harper, right, the young phenom outfielder of the Nationals. And after the game, he was indiscreet enough to say, "He's a rookie, you know, I had to drill him." They suspended him for that. But I think this was Jack Paul's, Cole Hamels moment. It was kind of, "Welcome to Lehigh here, rookie." But at any rate, my hope is that economics may be less useless than Jack thought, or at least pretended to think. And I had a few things I wanted to say about the healthcare system and healthcare reform. Some people think this is an oxymoron, simple economics. There's no such thing. But a few basic economic principles that I think maybe provide some insight into healthcare. And we can begin with a picture probably many of you have seen, and what it shows is that the percentage of GDP, of course, the total production that we have in the economy, that is devoted to healthcare has been increasing, and the projections are it's going to continue increasing. Right? So most of us have seen this. So essentially it means that more and more of what we produce in the economy, in the U.S. economy, is healthcare. So, question is, when will that stop? And economists have an idea they call Stein's law. I don't know if many of you remember Herb Stein. He was an economist, had an illustrious career. He may be best remembered these days for being the father of Ben Stein, right? The comedian Ben Stein. And Herb Stein served for years and years. He actually, after he retired, he actually, for a while, wrote this advice column. It was kind of funny because in the early days of the internet, you may remember this, it's still around, there's something called Slate magazine. It was one of Bill Gates's brainstorms. He thought, let's have an online magazine. And these days, that's millions of online magazines. But at the time, it was an innovation. And in addition to articles on economics and politics and literary criticism and whatever, he hired Michael Kinsley to be the editor. Michael Kinsley has kind of a humorous streak, I guess, and so he had this idea. He knew Herb Stein. He knew Herb Stein was kind of a funny guy, and he was retired from economics, so he hired him to write this advice column called Dear Prudence. And people would write in with their problems, and Stein would give these snarky responses. There was a little picture of him on the side of the column, wearing a wig and so on. And it turned out it was the most popular item, the most popular feature in Slate. And in fact, even after Herb Stein passed away, they hired a woman, and if you go on slate.com, they still have the Dear Prudence, only she turned it into a regular advice column. So you have this sort of odd thing that if you go on Slate, there are these elaborate discussions of how we should reform the tax system, and people talking about, the latest people to win the Pulitzer Prize and whatever. And then, there's somebody who wrote in, my boyfriend hates my cat, what should I do? And so it's a little bit incongruous. But Herb Stein actually started that, and during his economist days, he was the chair of the Council of Economic Advisors under President Nixon. And at one point, President Nixon became very concerned about some economic trend. Forget exactly what it was. It was something like the trade deficit was increasing month after month. And President Nixon was very upset about this, so he calls Herb Stein into his office, right? Herb Stein is chief economic advisor. And he says, Herb, when will this stop? And Herb Stein, like all economists, being a perfectly honest person, replied, Mr. President, I have no idea. However, I do know this. Something that can't go on forever won't go on forever. Right? So that is, economists have since called that Stein's law, right? Something that can't go on forever, won't go on forever. So here is my prediction. We saw that line going up on the graph. Healthcare expenditures will not become 100% of GDP. Right? They went from 5 to over 20. They will not become 100. But don't quote me. But of course, as like the man giving advice in Jack Paul's story to the person in the balloon, it's not all that useful to say, okay, the trend won't go on forever. At some point, it's bound to level off. So the question is, how high will they go? Here's one slide that maybe I should have put later in the talk, but if you can if you can look at it, we're going to refer to this later on. What it shows here is the orange lines are basically how GDP per person has been increasing, and the blue lines are how healthcare costs have been increasing. And one thing you see is in the 70s, the 80s, you see very rapid increases in healthcare costs. We've seen somewhat smaller in the 90s and in the 2000s. And the last one there is the projection for the future. Two things going on. One is still growing faster than GDP, but on the other hand, slowed down somewhat. Actually, I'm going to talk in a little while about why maybe healthcare, the increase in healthcare costs has slowed down at least a little bit. But you can see I'm not the world's greatest PowerPoint person. I've got this stray arrow. The arrow will come in a little bit later. So, what explains the graph? Here's one thing, and, this may make you cringe to the days back of Economics 1, but economists talk about elasticity. And one thing is called the income elasticity of demand. All it really means is how much are you increasing expenditures on something as your income increases. And some goods, economists call them inferior goods, not that they mean inferior, not in the sense of lousy, but inferior just in the sense that as your income increases, you don't spend proportionally as much, right? I mean, if tomorrow, if you were a founding member of Facebook, right, and your income just exploded today with the IPO, you're not going to increase your expenditures, say, on food that much. I mean, you may go to fancier restaurants or whatever, but certain necessities, we don't increase our spending on that much as we increase our income. This luxuries we do, right? So as our income increases, we're more, if we're a struggling student, we graduate, maybe we buy a car, and eventually we buy a house and things like that. So luxuries, meaning essentially we're just increasing proportionally our expenditures as our income, more than proportionally as our income increases. So then the question is, what is healthcare? Well, in many ways, if you look at the data, healthcare turns out to be more of a luxury in this sense than a necessity, you can say. Isn't it a necessity in the sense, I got to go to the doctor, and if I'm sick, I got to get some medication, or I have to have surgery or whatever. Yeah, in that sense, but in the sort of technical economic sense, we see people wanting to increase their expenditures on health care more than their income goes up, right? So there's certain things we increase less. Health care is when we increase more. So what does that tell us? One thing it tells us is that part of what's driving that line going up in that picture, saying as GDP has increased, we've spent more and more on health care, is people want more health care, right? It's kind of a basic point, but the idea that if it's a luxury in the sense that we want proportionally more as our incomes rise, it's not too surprising, right? If I put together a graph like that for, say, spending on smartphones or spending on LCD televisions, we'd see the same sort of thing, right? As our incomes have gone up, they would start at a lower level, but we would see people increasing their expenditures on those sorts of things more than they do on, greater than their income goes up. So that's part of what's always we're keeping in mind that, I said, is that a scary picture? Partly yes, partly no. The partly no would say, hey, as we become, as a country, as our incomes increase, it's not surprising we're spending more on healthcare. It's something people want, and so that part of it is not surprising. There's other things going on as well. One of them has to do with the costs, and TCM, Turner Classic Movies. I should drop that. Many of you know Phil Kent, right? The Lehigh alum who runs Turner Broadcasting System. He always asks me to drop in one of his networks, whenever I talk to people. So Turner Classic Movies. I'm a great fan of Turner Classic Movies, right? It has the old movies, many of them in black and white, many of them from the 1930s and 40s. And one of the things you tend to see in those movies is people of middle-class incomes oftentimes have maids, cooks, other servants. Right? If you think about the movie It's a Wonderful Life with Jimmy Stewart, right? Everybody, Christmas time, everybody sees that. You know, they're running this struggling savings and loan, building and loan. You know, they're clearly not a high-income family. They have a maid or cook. And, you know, one of my favorite movies, George Washington Slept Here, with the comedian Jack Benny. He's living he and his family living in this apartment in New York. He's clearly not a wealthy man. He has a cook as well. So the question is, today, though, you know, people at the same income level do not typically have maids and cooks. Why not? Well, something called that William Baumol, who's an economist at NYU, sometimes it's called Baumel's disease. Sometimes it's called the cost disease of the service sector. And basically, the way the story works is that if you think of the economy as the goods sector, where people are actually producing things, and the service sector, right, where people are producing things like doctor's visits or, you know, cooks, maids, and so on, productivity tends to increase faster in the goods sector. Right, almost across the board, increases faster. And ultimately, one of the things economics teaches us is that incomes tend to be, that productivity tends to drive incomes. So what we'd expect is that in the goods producing sector, as productivity increases, wages are going to move along with productivity. So wages are going to be higher in the goods producing sector. So what happens over in the service sector? Well, one of two things tends to happen. One is, well, what tends to happen to wages and costs is they tend to rise, right? That if you want to continue to have a maid in your middle-income family, you can probably do it, but you have to pay what is a pretty high wage, and an increasing wage, because there are opportunities outside of that sector that are increasing. Right, so as a result of that, a result of increases in wages in the goods-producing sector, the service sector, one of two things has to happen. Either one, it has to contract. And that's what we saw happening with maids and cooks, right? Essentially, they largely disappeared, or they, you know, are hired only by people who have high enough incomes to be willing to pay those higher wages. Or what we've seen in healthcare is, because the demand has been very high and the alternatives have not really been there, we tend to see costs rise. So Baumel's disease is that in the service sector, we tend to see rising costs. And you know, you can say, well, part of it's also sort of technology, right, is in there, that, you know, as dishwashers became available, you didn't need to hire somebody to wash your own dishes, or, you know, refrigerators became available after World War II. You know, people didn't need someone to go to the grocery store all the time for them or whatever. So the question is, does this work in the healthcare sector? Can we explain some of the rising expenditures on healthcare as a result of rising costs? Well, there have been a number of studies that seem to say, so here's the question. What happens if labor productivity grows more slowly in the healthcare sector than the rest of the economy? Healthcare costs are going to rise. And there have been a number of studies. The best one actually looks more broadly at just from the United States to what are called the OECD countries, which are basically the high-income countries: Europe, United States, Japan, a few other countries. And so it turns out that if you look at all those countries together, including the US, Canada, Japan, France, Germany, England, and so on, that productivity is growing only about 20 to 40% as much in the healthcare sector as in the wider economy. Not too surprising. Right? There's a lot of technological progress in the healthcare sector, but it tends to take the form of, you know, sort of better MRI machines or other sorts of things like that that really are not increasing productivity that much. And kind of like with education, right, ultimately, you know, you need the individual doctor meeting with an individual patient, individual doctor performing an individual surgery, and so on. Difficult to greatly increase the productivity. So in fact, as productivity outside of the healthcare sector and the economy generally goes up, it tends to increase healthcare spending for those same sorts of reasons that, essentially to keep workers in healthcare, you've got to pay them something comparable to what they could get outside of healthcare. And if their productivity isn't going up, those higher wages are forcing costs to rise. Okay, so this next one is really going to make your skin crawl a bit here. So this is really back in the world of Economics 1 with Richie Aronson or Frank Gunner or myself, whoever you may have had. And it's back in the wonderful world of demand and supply. And what essentially this is saying is that if costs are driven up, and that's what the supply curve is showing, and demand is not very responsive to price, which turns out to be true, and we can talk in a couple of minutes about some reasons why that's true, what are you going to see? What you're going to see is that spending is going to rise, right? So you get, as costs go up, you don't see a big decline in the amount that's demanded the way that you did for maids and cooks and so on. As the cost of them rose, people just said, well, I'll get by without them. That's not what you see in healthcare. There's not much responsiveness to demand, and so the price gets driven up a lot, and the total amount of spending goes up. So turns out Economics 1 has some explanatory power here. So let me go through some other things about what's not causing healthcare spending to rise before kind of getting to more of the punchline. One of the things always to keep in mind is a basic concept, the difference between levels and rates of change, right? So there's a difference between saying healthcare is expensive and healthcare costs keep rising relative to the rest of the economy. So the things that just say, this is why healthcare is expensive, they are not sufficient necessarily to explain why the healthcare costs keep rising. For instance, here's a bunch of level things. So inefficiency, duplication, waste. We hear a lot about this, and we all encounter it where, somehow, they lose your MRI, and you got to have it again, or the doctor who took the MRI somehow can't communicate it to the doctor who's actually going to diagnose what's wrong with you, and so on. So there's no doubt that there's a lot of inefficiency, duplication, waste, which raises costs. But to say, hey, that's what's driving the increase in healthcare costs relative to the rest of the economy, to say that, you'd have to say it's becoming worse. Maybe becoming a little bit worse. Hard to believe it's becoming sort of worse year after year after year, and that's what's driving the increase in cost. So we would be better off with a less inefficient, duplicative, wasteful healthcare system that would bring down our costs, but it wouldn't affect the increase over time because that's just a levels type of thing. There's also some people said maybe correctly that one of the reasons why the U.S. system seems like it's costly is we tend to measure the costs explicitly, whereas in other countries, one of the things I didn't show a slide for, but you probably already know that healthcare costs are higher in the U.S. per person than they are in just about every other country. And some economists have said, well, if you're in Canada and you've got pain in your knee, maybe you wait 6 weeks or something before they do an MRI, and then they say, oh, you need surgery, and you wait 6 months or 8 months or whatever before you get the surgery. Whereas in the US, you get the MRI next week and the surgery the week after that. And so people said, well, yeah, the costs in Canada are actually higher. They're just not explicit, right? Because, we're not measuring the fact that you're limping around for, an extra 8 months before you get your surgery. Maybe that's true. There's debate among health economists to extent that that's true. But once again, that's a one-time sort of thing. It doesn't explain why costs are going up. Malpractice costs. Physicians, will tell you, oh, I'm ordering these tests. I'm just covering myself, against the possibility that I missed something and, the person's going to sue my pants off. The Congressional Budget Office, the CBO, says that that's probably about 0.5% of healthcare costs. So even if we wiped it out, if we had a system that was perfect with respect to malpractice, we wouldn't say that much. And in addition, unless you think that's becoming worse, that doctors are becoming more and more defensive, ordering more and more unnecessary tests, it can't be explaining the increase in costs. Another cost is, the uninsured using emergency rooms who might otherwise have gone to a physician and had a less expensive encounter with the healthcare system. Estimates are, healthcare costs are maybe 1% to 4% higher than they would be if the uninsured had regular physicians. But once again, unless that was increasing dramatically over time, it would not explain. Some people say corporate greed. It's the medical profession and the insurance companies. They're out to screw us. Well, unless they're screwing us progressively more year by year, that can't be what's forcing up costs. Okay, so let me get to some of the problems that some economists see with the current system. First off, as most people know, a lot of people get their health care through their employer, right? So it's about half. This is for 2010. A few people buy it individually, about 5%. 17% of the population had no insurance, and the other 29% or so either got it through the Veterans Administration, through Medicaid, or through Medicare. And actually, before sort of getting on to the main thing I want to say, which is about the employer-provided insurance, there is one thing that we hear a lot about on the Medicare part, because some people say, gee, we're really in a bind for demographic reasons. That as people age, more people hit 65, they the whole baby boom is going through the 65-year-old point where you get to go onto Medicare. And, gee, we're going to have problems with that. Well, actually, one of the things not well known is, if you look at this graph, so this is just federal spending on health care as a percentage of GDP. And you can see, so the top line is looking at what the projections are all the way out to 2082. And if you look at that, the effect of the aging of the population just by itself, if you said, suppose we could keep the growth in healthcare costs equal to the growth of the economy, then what would aging do to federal spending on healthcare? The answer is not that much. Not that much. It's really not the aging of the population that's going to drive Medicare costs. It's really what the government calls excess cost growth, which basically means the increase in healthcare costs over and above the increase in the level of GDP. That's really what's driving it. You can see the effect of the aging population, it's there, but you should never give me an open bottle. I hope the next speaker doesn't slip on this. It's there, but it's not a huge effect. So really, what's driving it is that excess cost growth. So what is that all about? This is some stuff on the uninsured. I think I'll just skip through this since we're running a little bit late on time. So this is looking at the percentage of all firms that are offering health benefits. It bounces around some overall, the numbers, because this is done surveys by the Kaiser Foundation, these numbers bounce around more than is kind of plausible, but at this point, it's about 60% of all firms, and of smaller firms, it's down to about 50%. Here, if you can see it, it looks a little dark from where I am. What this is showing is that for higher income workers, and this is basically people whose family income is about 4 times the poverty level. So the poverty level is about $22,000. So if you're like at the $88,000 or above level, almost everybody has access to employer-provided health care. Right? 92% are covered by their own or their spouse's employer. You know, there's 4% who, for whatever reason, don't take it, and only about 4% of people who are in that category do not actually have access to employer health care. You can see for poorer workers who tend, obviously, to be working for smaller firms, it's a somewhat different story. Right there, it's only about 30% who have access to it, and you can see there's as much as 55% who don't. So one of the things that's going on, actually, let me skip through this slide as well. One of the things that is happening that may help to account for, oh, the rescue party is here to save me from sliding away here. One of the things that has happened to healthcare in the last few years, not as widely noted. Sorry for the mess.
I do this at home all the time.
I do too, but usually it's my kids I'm blaming, not myself. So.
I hire out, too.
We could use you, I'll tell you. We could use you.
Okay, then?
Oh, that's great. That's fine. Thank you. So one of the things that's happened is there has been a shift towards higher deductible plans. And you can see here what this is looking at, the percentage of covered workers, right, people who have employer insurance enrolled in a plan with a deductible of $1,000 or more. Right? So when you get to $1,000 as your deductible, you're in a situation where rather than comprehensive insurance, it's more catastrophic. Right? Because a typical person does not run up $1,000 worth of health care costs over the course of a year. And you can see there's been a tremendous increase for all firms, which is the middle line there. It's gone from only 10% offering this high deductible, or had employees covered by the high deductible plan, all the way up to about a third. For the smaller firms, it's now up to half. And these are small firms defined as fewer than 200 workers, right? So many of those are what we'd often think of as medium-sized firms. So this is just showing how. Okay, so the critique many economists have, if you boiled it down to its nubbin, is we have a system that's kind of a market system for healthcare, but relies very heavily on employer-provided healthcare, which is really a quirk. Many people know this, right? It was a quirk of the law during World War II, right, that wages were frozen, but employers were allowed to pay health care benefits uncapped without having to count them against wages. That is the origin of employer-provided health care. It was then ratified by writing into the tax code, right, provisions that allow for that payment on behalf of employees not to be taxed as their income and to be deductible from the costs of the firm. So economists talk about moral hazard, right? It's a big concept in economics that basically says once you're insured, you change your behavior. There's been a lot of talk about this on Wall Street, right? The too big to fail firms. You know, have they changed their behavior because effectively they feel as if they're insured against failure by the federal government's willingness to step in? You know, a company that might be considering putting in an elaborate, sprinkler system into their into a warehouse, if they have fire insurance and there isn't a rider that requires them to have a sprinkler at a certain level, they may cut corners there. Clearly, it's true with respect to medical insurance, healthcare insurance. Because if you think about it, if you have, say, a 20% copayment, then effectively you're only paying 20 cents on the dollar for your health care, over and above any deductible that you may have in your plan. And so what does that mean? Overutilization, right? You're going to buy more health care than you would if you had the same price. And in fact, this economist speak Newhouse, just a fellow who had a particular study. There was this RAND study that's widely used, one of the few sort of experimental studies where they randomly gave people different health care plans, and then they saw how that affected their behavior. And one of the things they showed is that if you have high deductibles, it reduces healthcare spending by up to 50%. In other words, when people have to pay their own way in healthcare, they tend to spend less when they don't have that, subsidy. And in fact, over time, one of the things we've seen is that the amount of healthcare expenditures people pay out of their pocket has declined tremendously. Back in the 60s, something between 40 and 45% of all healthcare spending, people were paying like they pay for their food or their clothing or anything else, and it's down to about 10% today. Another aspect of insurance is typically it's best at covering uncertain high-cost events, your house burning down, right? That is something where insurance works the best. But employer-provided health insurance covers a lot of planned things, right? Lehigh's plan covers, an annual physical for me, vaccinations. I get allergy shots. It covers that at 100% or so on. Those are not high-cost, uncertain events. I know I'm going to get an allergy shot every month. So it covers small expenses, doctor's visits for minor illnesses. Ordinarily, that kind of insurance is a bad deal, right? If you read Consumer Reports, they say if you buy a vacuum cleaner, you buy a lawnmower, never buy the extended warranty, right? Because effectively, right, you're insuring yourself against a $200 loss if you have to replace your vacuum cleaner, or $400 or something for your lawnmower. It's bound to be a bad deal, right? Because the company has to pay out less than it's taking in. And so why should you pay more for, this small unintended event? Don't do it. It's a bad deal. You're better off, paying for the $200 or whatever when you have to replace your vacuum cleaner. But then why is it that I end up getting, essentially, by covering my vaccinations and, allergy shots and whatever, I've bought insurance from Lehigh for a vacuum cleaner, right? I mean, the allergy stuff I had to pay it out of my own pocket would be like $35, not $200. Why is that? Well, the answer is the huge tax break, right? The reason that it makes sense to do that is because how the tax code is written. And it is the biggest tax break there is. It's even bigger than the mortgage insurance deduction. It's about $250 billion per year. It's the largest tax break that there is. And if you think about it, what if everything worked this way, right? What if Lehigh said to me, you know what, we're going to insure your groceries, right? This is what we'll do, every month you just, we'll give you this card and you go to the Giant or you go to Wegmans or something and, you swipe the card and we'll pay for it. Of course, we're going to reduce your income, but, you don't have to pay taxes. Well, of course, they actually couldn't do that because the tax code wouldn't allow them. They could set it up, but then that would still be considered part of my taxable income. We know what the result of that would be. I would, spend more at the grocery store if they gave me, a car insurance. We'll pay for your car and we'll take it out of your income. I would be basically saving a third or whatever of whatever the thing cost me. There is another quirk in there that what Lehigh is paying on my behalf is completely deductible for me. I'm going to put that up there so I don't knock it over again. My out-of-pocket expenses, though, are only deductible if they exceed 7.5% of my adjusted gross income, which is going to go up to 10% under the new plan. That's worth only about $9 billion, right? So there's a tremendous tax break for the employer-provided benefit, not much of a tax break if you pay for it out of your own pocket. So the tax code clearly biases in favor of employer-provided blank one screen. There's health savings accounts, but not many people use them. 600,000 people and the tax savings are very small. And of course, if you're in a state, in Pennsylvania, it was like 3% tax, you're saving that as well, right? If you're in, if you're in New Jersey or New York or California, you're saving even more by having your employer effectively pay part of your cost, namely your healthcare costs. So here's the EcoSpeak summary. The current law, before the patient protection and whatever, the Obamacare plan kicks in, clearly the current law reduces the cost of medical spending, biases that spending away from out-of-pocket spending toward employer plans. And so, economists like to talk about margins, meaning, am I buying a little bit more, a little bit less? Medical versus non-medical spending, clearly we're pushing people to buy more medical spending, but to spend more of their money on healthcare. Why are we doing that? Why is that happening? Because we've greatly reduced the price, right? If I'm paying only 20 cents on the dollar for healthcare costs and $1 on the dollar for food and clothing and everything else, and LCD TVs, I'm going to buy more healthcare relative to that. So there's built into the system is that bias. And also we're biased towards people wanting their employers to provide it, right? Because if I say to Lehigh, no, give me the money in cash, I'm going to pay out of my own pocket for my health care, unless my health care goes above 7.5% of my income, I get no tax break at all. Okay, so this is, some people say, well, could you, let me skip through this, it's too much EcoSpeak. Let me skip through this as well, since we're really almost done. Okay, so what would market-based reforms look like? Who knows how the election will come out, but Mitt Romney has said, he wants to repeal the Obama health care reforms in toto. So what would he do? Presumably, from what he says, he hasn't spelled it out. You want to be cautious about these things. Increase the impact of price signals to reduce moral hazard waste. In other words, to make it look more like a market, right? How could you do that? One thing a lot of people have said is, if part of the problem is because of the tax code, we have people getting their insurance through their employers, you could eliminate that. Really hard to do, right? The unions who tend to vote for Democrats, they don't want it done, and Republicans who don't like to see any tax break eliminated of any kind are going to be against that. So one thing that you could do is you could make out-of-pocket expenses deductible. You could say, okay, there's a bias towards having your employer pay for your health care. What if we leveled the playing field and said, if you spend it out of your own pocket, you can deduct that as well? Well, that would help. That would help. But we'd end up subsidizing all health care, right? So that would clearly potentially increase costs and increase waste. Yeah, let's skip through that. One thing that is sometimes done, sometimes argued, is having a fixed dollar deduction for out-of-pocket expenses. Saying what we're going to do is we're going to give people a fixed amount that they can spend for their health care, and there would be a smaller subsidy. You'd reduce some of the incentives to overspending, and I better stop. Yes, well, let me answer questions rather than ramble on with these things. So, do people have? Got to be back here. People have questions coming? Yes. Take 3. Well, here's the story I think that economists, I didn't quite have enough time to get into it. Economists would say essentially we're relying on the market to provide this service, right? We have physicians who are independent of the government by and large. We have people making their own purchases, but we don't really have a market because of the heavy subsidies that we give to employer-provided plans. So I think if you were to ask most economists, they would be inclined to say, First, what you have to do is sort of level the playing field so that there's more cost sharing, right? So that when people buy health care, they're facing the same kind of situation that they do when they buy anything else that they buy. Right now they don't because it's heavily subsidized. So the idea is that if you got rid of the tax deduction for employer-provided health care, right, people would not have the incentive that they have today, which is to get low deductible, low co-payment plans. I mean, it's in my best interest to have Lehigh pay as much as possible of my health care costs, reduce my income by a corresponding amount, but it still saves me a third of what I otherwise would have spent.
That's why the high deductible plans work. Because you pay the same amount of money, give you a $3,000 deductible and the cost amount, give you the $3,000, then you've got the money and you're not going to spend it because you can keep it.
That's one of the things that we see. We see a movement towards high deductible plans. Yeah, his question was, what was the solution? And we were talking about the possibility of having higher deductibles. We're seeing that already. If you look at, in the Obama plan, if you look at what the basic plan is going to look like, they are high deductible plans. And the idea with the high deductible plans is it makes health care insurance look more like fire insurance or automobile insurance. That what you're doing is you're insuring against a catastrophe. The other stuff, you know, going to the doctor, getting a physical, those kinds of things, you end up paying the whole cost for yourself. Yes?
So we went on a high deductible insurance this year, and then I had a catastrophic injury. What was interesting about it, though, was that it actually paid for all of the routine care as well. It was just the in-between stuff that it didn't pay for. So a child visit or immunizations it paid for, but then I had to wait $3,000 before it started to pay anything on my injury. So I appreciated it, and I will continue on it even though, but it's very complicated. You know, every single bill I get now, I'm always tracking again how much I spent, how much is the deductible, where am I at in it. I almost feel like it's added more confusion to our medical life than
Yeah, I mean, part of what's going on, I think, with the child vaccinations and some of the other things, and we've seen, you know, the controversy over provision of contraception and so on, is there are a lot of mandates, right? There are a lot of mandates that are built in there, and one of the things that we don't have now, and many economists have pushed for and not really ended up part of the Obama plan, is to have more competition across state lines. Some people have said, well, you know, you get a race to the bottom, meaning that, you know, you have bare bones policies. But one of the reasons why, one of those slides I really quickly went through, is you actually have a substantial number of people who can't afford insurance, who are young, and who opt out of the system, which is a problem. The real why they're opting out of the system because the plans that they're offered, sometimes because of state regulations, have a bunch of stuff in them they don't feel that they need. I mean, if they don't have any children, they don't want to, you know, child immunization, that does nothing for me. What they really, if you're 25 and you're in good health, what you're really worried about is an automobile accident, a sudden illness, and so on. You really want catastrophic coverage. If you're forced to buy a whole bunch of other stuff, the price is going to be higher. You may opt out of the system, which is a problem, both potentially for you, if in fact you have the car accident, and then also for the system as a whole, because you're not paying into it, right? And so you're not, you know, you're not helping to subsidize.
So from an economist's viewpoint, assuming Obamacare survives the Supreme Court, does requiring everybody to buy health insurance, is that going in the right direction, or is that not going in the right direction?
Well, it's viewed by itself. There's no doubt that you've got a huge adverse selection problem if you don't force everybody to buy in, right? Because if you say, you, Mr. 25-year-old, you can avoid the paying anything in, and then if you have that car accident, you sign up, we got to cover you. So we're missing the years when you were paying into the plan. But I think most economists would say that that's sort of a minor part of the story, that the critique a lot of economists have of the Obamacare plan. There are economists who like it, but the one critique is we really didn't move very far towards the more market-based plan. They made some initial attempts. If you remember, they were going to start cutting back on the tax deductibility of the employer plans. It's still supposed to phase in 2018 above a certain level, and there's a lot of people who think, that won't happen even in 2018 because, the political forces behind that deduction are so high. Yeah?
I guess I'd make the observation that as a nation, if we don't have a healthy population, we don't have a healthy economy. And it just doesn't make any sense for huge segments of our population to die early, have poor treatment and care. And so, economics aside, that is a big economic discussion. Are we going to have a healthy workforce that employers can have and compete or not? My question would be, is it necessary to have private medical insurance companies with their profit motive particularly involved? I mean, I know of one senior medical insurance executive in Indiana who was let go from WellPoint. He was given an $8 million severance, and every penny of that came out of our healthcare premiums. And, so I question whether a single payer versus having all these private insurance companies, all with everybody making a profit is the right one.
Yeah, you can make an argument we sort of have the worst of both worlds, right? Because we have private companies providing these things, but they're heavily regulated, and they can't always offer what they want to offer. They have to offer what the state government tells them to offer. You're right. I mean, a lot of the studies have shown that the additional money, the marginal money that is being spent by middle-income people and above on healthcare doesn't seem to have much payoff, right? So, if Leah's going to pick up my visit to the doctor, and I think, got a sore throat, maybe I'll go and have tested. I have strep throat, don't have strep throat, and because if I'm paying 20% instead of the whole doctor's fee, there's not much of a medical benefit to that, and a lot of money gets spent on that. If you look at poor people, you get a much bigger increase. I mean, because if you're in a situation where you have a significant health problem, and you're not going to the doctor because you can't afford it until you're so sick you wander into the emergency room. So we kind of have the worst of both worlds there, right? So we're subsidizing me, right, which effectively is what happened. That $250 billion is coming from everybody, right? I'm being subsidized because I don't have to pay taxes on what Lehigh is paying me. I get that money, without having to pay taxes on it. And so you're subsidizing me for, going to the doctor more often than I should. On the other end of the scale, the person who doesn't have access to Lehigh's health plan, they actually would have a good health outcome if they would go to the doctor, more than when they're in catastrophically bad shape. So in that sense as well, the current system is, the subsidies are cockeyed. Yes.
This discussion is focused mostly on the consumer expenditure and insurance aspects of healthcare, but the $2.5 trillion that's spent mostly has to do with the way healthcare is actually delivered. And there's a good argument that that's actually an even bigger problem. Today's system compensates providers to see patients more often, as opposed to compensating them for making us healthy. So we're going to have a volume-based incentive system instead of a value-based incentive system. The biggest elements of the Accountable Care Act change that by implementing patient-centered medical homes, accountable care organizations that focus on the population of a head count of people, a population of people. And that could save billions.
Yeah, I mean, right. There are certain incentives that are in the new plan that a lot of economists are anxiously looking at. I think one of the things that economists have been critical of over time is how we've kind of short-circuited some of that experimentation that might otherwise have taken place by, for one thing, not allowing competition across state lines, by having a lot of mandates that, so, one of the wonders of the market system is you get a lot of experimentation. People try this, it doesn't work. Try that, it works. And gradually the things that work drive out the things that don't work. We've short-circuited a lot of that from the system that we've actually got set up.
I would say also that healthcare costs are going up faster than we think because people are not living as healthily as they did before. As GDP rises, they get less exercise, and they live longer also, and they eat they eat too much, so they become too heavy. They have greater medical expenses because of being overweight, and also they're eating more manufactured foods which have all kinds of chemicals in them. And a lot of go to the grocery store, and look at the label and see what the chemicals are in there.
Real quick, why not have a different plan for those younger people who don't want to opt into the whole vision plan? Let them have the catastrophic for a different price. Would that be a possibility in this kind of program?
The answer is it's a possibility. In some states, it's not allowed. So there are certain mandates that are in, that are in there, and if you want to buy if you want to sell health insurance in New York State, you have to provide certain things. Yeah. So, but that's right. I mean, moving that way makes insurance look more like, makes health insurance look more like other insurance, where if there's some peeling paint on my house, I don't call up Liberty Mutual and say you got to send somebody over here, to paint. What I do is I do it myself, or I hire somebody out of pocket to do it. If my house burns down, I call Liberty Mutual and say, I need help. But we don't do that with healthcare, right? With healthcare, in effect, Lehigh is sending somebody to my house to scrape the paint and paint it for me. And naturally enough, then every little blotch on my house, if that were the kind of insurance I had, I would have somebody out there doing it. That's effectively what we've got with the health insurance system that we have today. Great. Well, thank you very much. I enjoyed it.